Hi, how are you doing?
Yeah, hi. Good afternoon, Sean. This is Amit from the auditorium.
Hello there, hi.
Yeah. So, could you tell us about the case?
Well, this is a gentleman who we saw this morning who's got a history of, as a teenager, of recurrent dislocation of his patella. He works as a farmer locally.
Okay.
Over the years, his patella's actually stabilized, but one of his main complaints has been of lateral joint pain. And when we examined him this morning, he was very, very tender over his lateral femoral condyle. So we've just actually done a arthroscopy of his knee, which I'll whiz through the sort of salient features. One of the most noticeable is there you can see basically he's got a completely flat trochlea.
Right.
He's almost got no trochlea at all the way down to the top of his intercondylar notch there. A little bit of narrowing of his notch.
Yes.
On his medial side, he's got some osteophyte formation on his medial femoral condyle. But as we've gone into the medial joint, surprisingly, and this is a guy who's had a fairly recent MRI scan,
Right.
which did not show this at all, we have got this on his medial femoral condyle.
All right.
Right? So
Okay.
we've got a pretty nasty, full thickness lesion on his medial femoral condyle, which remarkably is actually quite asymptomatic at the moment, but I don't think it's going to be for very long, which we're going to have to address.
Okay.
When you go up onto his lateral side, he's got a fairly diffuse area of wear up on the proximal aspect of his lateral femoral condyle with some loose articular cartilage flaps here. But the bulk of his lateral joint, if we can just swing this into the figure of 4 position again for me, please. Right here. There. So when we go on the lateral side of his, sorry about that, joint, and just use our probe to reflect the fat pad and everything out the road. And then, can one of you just slowly straighten that knee out for me? See, his lateral joint looks pretty pristine there, and all the way, keep going, keep going, keep going. Keep going, fantastic. So as we unfold the lateral joint in front of us, and then we've got a pretty nice view of the meniscus and everything. That's all okay, apart from this proximal lesion. So, unfortunately, this is not a contained defect. So, it's right out to the periphery. He hasn't got an associated lesion on the underside of his patella. So, what I'm going to do is I'm going to debride this area and then address that significant grade 4 lesion that he's got on his medial femoral condyle. So what we'll do is maybe do that medial femoral condyle first. I think that from an articular cartilage lesion for the audience is going to be the more interesting one to deal with.
Yeah, that's correct. So, if I may ask you, the lateral lesion is, you think is because of the patellar dislocation, because of the direct impact of middle facet of patella over there?
Yeah. I think over the years his patella's been sliding in and out because of a dysplastic trochlea many times. Surprisingly, he hasn't got major wear on his medial facet of his patella. That's in pretty good nick. So I'm surprised at that. So have you got the shaver available?
Yeah.
So I'm just going to, and it's on a foot pedal, is it? Let's get rid of a little bit of the fat around here because that's going to be, is it on oscillate? Can you stick the shaver onto oscillate? Is that in the middle?
So, what's your plan?
Well, I'm just going to see how big it is,
Uh-huh.
and then I'm going to decide whether we can do a mosaic plasty or whether we should microfracture this lesion on the medial femoral condyle.
Okay.
My first line of treatment normally for an osteochondral lesion, to be quite honest, is a microfracture. I then use mosaic plasty maybe as a fallback, or an ACI if I can get. One of the problems with ACI in the UK is it's limited because of the amount of money it costs.
Okay.
And there's a thing called the National Institute of Clinical Excellence, which dictates what we can and can't do. And they've deemed it still as an experimental procedure. So you've got to make special representation to be able to do it or be part of a national trial. And I was part of the national trial, but that's now over, and we're just waiting for the results to come through. So just using the shaver here really to get rid of the fat, so we've got a nice view, so we can see exactly what we're dealing with. So can I have that probe back, please? So at first glance, you can see there's a lesion there in your medial femoral condyle, but you've got no idea about how big it is. And then without a great deal of effort, you can see how it's really quite a significant lesion. Wow.
It's quite surprising that this lesion is asymptomatic.
Yeah, but the thing is, you can't believe that that's going to be asymptomatic for much longer. Have you got a punch, please? Straight punch, yeah. Have we got a nice curette on the set as well? Punch first, no? It's always a difficult dilemma what to do with an incidental finding. Let's say the amazing thing is that this wasn't visible on his MRI scan. So then dealing with any chondral lesion, the first thing you've got to do is get back to a stable base. Yep.
Is your debridement any different if you were to use, microfracture or osteochondral transfer? So is there any difference in the debridement of the lesion?
No, they've both still got to go back to a nice, strong, stable base because you want ingrowth of the articular surface from these strong edges. Well, I think if you leave the loose edges, you will end up with articular cartilage flaps that will irritate. There isn't an option here to do this, but when it's like this, when it's almost like a delaminating lesion, and it's coming off, you think if you could have some form of tissile glue to stick it all back down, it would be fantastic. But, right, have we found a curette yet?
It's a fairly large lesion.
It is, yeah. Once we've got on the mosaic plastic set, we've got the little sizer. The one we've opened is the 8mm cores, so we'll have a little look and see what it's like. But I think it'll be, when you think this probe, this shaver blade is 4.5. Mm-hmm. And that's not taken up much of this guy's. No, it's fine. But they say once a lesion's over 4 centimeters squared, you really shouldn't be doing a mosaic plasty.
That's correct.
Habgodi might argue against that. He seems to mosaic plasty the whole femoral condyle. Mm-hmm. But what's that, sir? Yeah. How's ACI coming on in Australia? Is it being used regularly or not?
Sorry?
And then, Dr. Nang, are you managing to do any ACI at all?
No, I personally don't have any experience in ACI, but yes, it is being done in India.
Yeah. I think the jury's still out on it. I think like everybody, the results of the initial work by Pedersen out of Gothenburg doesn't seem to be getting replicated by everybody else. Right. But Matt Brittberg and Cole in Chicago are certainly plugging it, aren't they?
I think it's a question of what is the size and what are the patient's requirement. Otherwise, I think most of these procedures, they don't compete with each other. They complement each other.
Yeah. I think they're just looking to see if they can get me a nice curette just to sharpen up these edges a little bit, but I think we're getting there.
So you perform your mosaic plasties all arthroscopically, or does size have a bearing on?
It depends on how many plugs I'm going to put in and where they are. If it's a single isolated plug and it's easily it's easily reachable to get a nice perpendicular. You know, this one, if you just had a plug going in there, you could do it quite easily arthroscopically because you could get it in at right angles to the bony surface
Yes.
relatively easy. But if it's in a more tricky area,
In a lesion like this, if that's the lesion and we are doing mosaic plasty, do you think arthroscopy is the way to go, or by doing arthrotomy?
I think with a lesion this size, the easiest way to do it would be to make a small arthrotomy.
Right.
Yeah, I think there's no point in making life too difficult for yourself. Right. Yeah. I just like to get, yeah, you see it extends even further up, doesn't it? Where does it stop is the question. Right. Can you just straighten the, we'll just straighten that knee out a tiny bit. Just so we can just see the top of the lesion. See a slightly better angle with the instruments. No. Just let it bend again. Just let the leg bend. Yeah, yeah. Just let it flex over the bed. That's good.
It's extending into the trochlear groove, or
Pardon, what was that? Sorry.
is it extending into the trochlear area?
No, it's safe on that front. Trochlear's more there, isn't it?
Okay.
And it's not, as I say, trochlear is very, 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 very shallow. So, but that's a pretty, that's a pretty decent view of where it is.
Yes.
It's very unfortunate. It's way smack bang in the weight-bearing area of his femoral condyle. But the other thing that you've got to do is prepare the base by getting rid of the calcified cartilage plate. Right.
You want correct?
Have you got it correct? Yeah. Fantastic. Oh, lovely. Wonderful. Just flex that knee down a little bit more. Excellent, that's fine. That's lovely. I don't want to breach into that inner wall of the trochlea, into the intercondylar notch there. Try and keep it a contained defect. Are we starting to run out of water? Are we? We're just getting a few bubbles. Just relax.
No.
Just let it all flop there. That's good. There you go. That's great.
वो स्लाइड नहीं है तो उसने स्लाइड निकाला लो सर वो हाँ
Right, so you've got to just the curette again, please. Just the smaller end. This guy was telling me before the operation that he's got 8 hectares. So it's a reasonable sized farm by British standards. It's probably I would imagine probably a small holding by Indian standards.
No, it's not small by any stand.
Yeah.
Do you think with the British standard bigger than that?
Yeah. Now, right, can you, so as you can see, I think we've got a fairly nicely well demarcated lesion now.
Yes.
Unfortunately, it is taking up a huge amount of his medial femoral condyle. So have you got the little sizer? And in the tubes, there's the straight punch, that's the one. No, the other one? That's the one. Yeah, great.
Mr. Sean, there is a question from the floor.
Yeah.
This much of cartilaginous lesion, can it be because of osteonecrosis, something like spontaneous necrosis of sonk or something?
Well, you would expect if it was sonk, you'd almost certainly see some reaction in the bone on the MRI scan.
Yes.
But I can actually reassure you that this MRI scan on the medial side of his joint looked entirely normal.
So you think this is traumatic?
I think it's traumatic, yeah. So this is the sizer for the 8mm Arthrex plugs. So if we were going to do a mosaicplasty, we'd need 1 there, 2, 3, 4, 5, 6. So you've got 8mm, 6 times 8. You know, I think it's way above the 4. I would personally microfracture this, and I think that's the way I'm going to go. I think it's a lesion crying out for a microfracture. So,
Yes.
we got the microfracture probe, please? No, the little awl that you gave me before? No, the one with the brown handle? That's the one. Yeah. Fantastic. Microfracture was actually invented in one of the hospitals I trained in 1953 by a guy called Priddy. But he didn't, he used a drill.
Yes,
And he didn't have a particularly good rehab regime.
Yes.
And hence, it worked and it didn't. And that's where Stedman made all the difference, is he invented the probe so you don't heat the articular cartilage.
Yes.
And then he developed this fairly strict, but what seems to work, regime. Now, a lot of people use a hammer to hit them in with. I'm just actually pushing these in at the moment.
So, do you think it's important to take the cartilaginous layer down before starting this making the microfracture holes? Or?
Yeah. That's why I've gone over the base of it with the
Shaver.
the shaver.
Okay.
Yeah.
5 minutes. The other team has finished ACL and PCL, so they just want to show for 5 minutes the final picture.
Right. Well,
We off.
yeah. You're going to pop back to the next theatre. So what I'll do is I'll just continue doing this microfracture, and I'll hopefully show you the end pictures of it. Okay.
Okay. So,
Right. I think we're going to have to. It's starting to get a bit tough. So I think we're going to have to be starting to.
Raju, is there?
Have you got the hammer? No. Just hit the end of it with a hammer.
What is saying?
Yes. Slowly.
Continue doing this.
Yeah. Keep going. Keep going. Lovely.
Pushing.
And again. Excellent.
Now is that?
OT2.
Yes. Dr. Amite,
Yes, sir.
we have finished. We have done a double bundle PCL reconstruction, which we have already shown.
Right.
And now we have. Can you appreciate that we have done an ACL reconstruction as well?
You can see that. Yes.
So they are very good relation. They are crossing
Yeah.
each other. There is no impingement.
Yes.
So
You
So
have
this is single bundle ACL, I presume?
yeah, single bundle ACL and a double bundle PCL.
Okay. So you have tried to preserve the ACL remnant as
Yeah,
possible.
yeah,
That's
yeah,
what I
yeah,
can see.
yeah.
Yeah,
Yeah.
that's very nice.
So,
Thank you very much.
Thank you very much. Okay.